choose to look at it, the lens I want you to appreciate, is first, as you're weighing the evidence, if you have a treatment that's a currently accepted treatment that's doing really well for patients, perhaps we should keep doing that. If we have some conditions that we have no really good treatments for, perhaps we should safely look for something else, responsibly look for something else. So the lens I choose to look at it is, what is the currently accepted standard of care treatments? What is the evidence supporting those treatments? And then we want to look at what are the, we're no longer talking what are the alternative treatments. I don't even like that word. What is the evidence for the regenerative treatments that we currently do for the same conditions? We want to know, is it safe? We want to know, is it FDA approved? We want to know, is the cost to benefit ratio reasonable for our patients? This is how I look at my patients. I bet you look at it similarly. So this is a picture you may recognize, a historic picture of a regenerative medicine physician circa 2005. So, and for those of you that were there, you know what we mean. We got beat up. We were told that what we were doing was fringe or cutting edge, even though we knew it was safe, even though we knew we were having good results, even though there was nascent evidence that supported its use. And there it is, a little higher granularity image of that guy. And there he is in my office. We're actually doing, this is in the pre-hood era, it goes way back. And we were testing different spin rates for PRP and doing open transfers. But it started back then, and it continues now. So as we go forth, what I want to give you is a plan, a battle plan, and you and I are going to scheme, and you're going to walk out of here walking like a giant, not standing on the side of the wall hoping someone chooses you to dance. We're going to go on the offensive. But to do that, we're going to need guns. We're going to need lots of guns. So here we go. Standard of care, what are the therapies that we're using? NSAIDs. Okay, you go into a normal doctor, you got something wrong with you, an Aaom, he's going to give you some NSAIDs. What do we know? We have 2 Cochrane level reviews that show they don't do anything to improve tissue healing. We know this. It's just analgesia, it's just sweeping a problem under the rug at cost. The cost has significant adverse events. These are not benign drugs. They have cardiovascular toxicities. They have GERD and other GI toxicities. So, but interestingly, what's their effect on healing? So the orthopedic literature is now pretty solid against, if you have a fracture or fracture healing, that NSAIDs, the evidence comes down squarely against fracture healing and NSAIDs. What else do we know? This was an interesting series of studies that was done by Trapp et al. It started with a rat study, it went on to a human study, same construct. Acetaminophen group, ibuprofen group, control group, heavy negative eccentric exercises, and then they looked for, was there active muscle protein synthesis in either group? In the rats, they sacrificed them and they weighed their quads and their hams. In the medical students that got the thigh muscle biopsy, they did not sacrifice them, they just took the thigh muscle biopsy. But what they saw was there was no muscle protein synthesis in the presence of these cyclooxygenase inhibitors. This means that it's inhibiting the initial healing response, the vital healing response that leads to healing. Corticosteroids. I'm not sure why we're having this conversation, but I'm just going to give you the evidence for it. So this is published in The Lancet by Coombs et al., meta-analysis, 41 included trials. And what did they see? They saw that the non-injection groups all had better pain and function at 4 weeks. Holy crap, why are we still injecting tendons with corticosteroid? Why is that what people are being currently taught in their sports medicine or orthopedic fellowship, that this is what you do for these things? It is unacceptable. We have good, solid evidence. That's not new. Published in the highest impact journals. It's curious why this still goes on. Okay, this McCallendon study was published in JAMA in 2017, and it was a very well done study. It was in knee osteoarthritis with 2-year follow-up, MRIs before, MRIs after. And what they found was when they went and unmasked, this is what they saw was corticosteroid injections versus saline injections. And what they saw was not only did the corticosteroid group not have any improvements in pain over the saline group, but they had worsening of their symptoms. They had progression of their arthritis. They had acceleration of their arthritis. Is this something new? No. American Orthopedic Hand Association, do you know what their recommendations are for small joint injections of corticosteroid? Lifetime. 3 injections. This has been their guidelines for over 20 years. Is the hyaline cartilage in my fingers different than the hyaline cartilage in my knee? No. It's the same. We've known about this toxicity both in bench work and in studies, yet if you go to a doctor, it will be covered by insurance to inject your knee with corticosteroids. The results aren't there, it accelerates arthritis, it's not good medicine. If you want to go on a Disney cruise, and you've already paid for your Disney cruise, and you just need your hip to feel better for 2 weeks, all right, I got the medicine for you. Short of that, there's no reason why we should be doing this. This is not good medicine. Epidural steroids for lumbar pain, this is another one. I remember being in my pain fellowship on a nationally televised meeting that we were having, and I said, hey, what are we going to do about this evidence? Because 21 randomized controlled trials in a Cochrane review says this stuff isn't working. Corticosteroids, all comers back stuff, is not working. What are we going to do next? I wanted to know. And there was no answer. There was crickets, because as long as the insurance companies are still paying for it, they're still doing it. And I am not sure why that is the case. Another one, epidural steroids, large RCT. They looked at it and they said, hey, there's no difference between corticosteroids and saline for something that's commonly treated with lumbar stenosis. Yeesh, why are we doing it? It's a curious question. Destructive modalities. Nowadays, you have these new protocols for ablating nerves wherever there happens to be pain. Well, nerves run with arteries, and arteries do something. I remember from medical school. Give me a second. But these are not good things to destroy. So what happens when you do a median branch block? I'll tell you what happens when you do a median branch block, and we don't consent our patients to it. When you go in and you ablate the median branches above and below a facet joint, you're doing that to get the sensory input to that facet joint to decrease the patient's pain. Good, decreasing pain, good. What else does it do? It does motor control to the multifidus at that level and leads to fatty infiltration of the multifidus and further destabilizes the spine. Does that sound like a good deal? Do you want that? Do you want that for your patients? Surgery. I have nothing against surgery. They form a vital part of our community. Many of them are our friends, and they do great work for our patients. And they really do, I believe they really want to do the best thing for the patients. But there's some curious stuff going on right now, and I don't know what to say about it. This is published in British Journal of Sports Medicine, and they don't do this often. They came out with a clinical practice guideline. And if you look, this came out in 2018. And what did they say? They said, we make a strong recommendation against the use of arthroscopy in nearly all patients with degenerative knee disease. They went on to say, based on linked systematic reviews, further research is unlikely to alter this recommendation. This is pretty hard stuff. They go on to say, this recommendation applies to patients with or without mechanical symptoms. What we classically were taught, like, hey, if you have locking, we need to have surgery. So this would mean, right, that the rates of arthroscopy in this country have gone down, right? No. Everyone needs a clean out. You need a clean out. But we have 6 RCTs that say that's not true, that it doesn't result in anything better. The rates in Europe have plummeted in knee arthroscopy. In this country, they've stayed the same because wife number 2 and the new boat isn't going to pay for itself. So when we look at rotator cuff tears, it's a harder one to parse out, but really, whether or not you had surgery or didn't have surgery, you had conservative care, we didn't see a difference in a couple of RCTs. This is now 3 RCTs, came up with pretty good numbers, came up with the same result. So this makes you say, if you have a rotator cuff tear, is it a reflex that your patient needs it? No. And I'm not saying that they don't need rotator cuff tear, and I'm not saying that there's not circumstances where these selected patients are going to be much better. It's not what I'm saying at all. But we have to consider that there need to be other treatments that might work. Arthrodesis. Who thinks this is a good idea? To fuse levels in your spine. We know what happens. It's a mechanical system. You're fusing levels, and you're just translating stress to the non-fused levels, and it results in further surgeries. We have high fail rate on that surgery. Disc arthroplasty, the fail rates, if you look at them, remarkably, I've checked my numbers to make sure I didn't transpose something. It's the same, but it's better than that. So I'm a sports medicine physician, I'm a board-certified pain physician, and what did I see as a pain physician? Of course I'm a little jaded because, I don't know where to point this thing. Failed back surgery syndrome. Yeah, we made that term up. Failed back surgery syndrome. Actually, we didn't make it up, it's a known thing. 40% of lumbar surgical cases. Holy cats, can we beat that? I bet we could beat that. Over 5,000 patients a year die in knee and hip arthroplasty. This is a real number. How many patients in FDA-approved autologous stem cell treatment have died? None in this country. Rehabilitation, I have nothing against rehabilitation. And frankly, rehabilitation is a vital part of every treatment plan that I do. You need it, but it doesn't fix everything. And that's the literature that's saying this. In a couple examples of looking at whether it's pine or lumbar spine stenosis, it doesn't cover it all. Because like they say in Maine, sometimes you can't get there from here. Sometimes the patient can't bridge their injury to be able to benefit from rehabilitative exercise. That's where we come in. We help them bridge. Now, sometimes it's a surgical option that is the best thing for the patient. But oftentimes, we have good options that are very acceptable. So if you think of this as a construct for cellular medicine, it is not the only construct, but it is a construct to think about this. We have really, they're all stimulating the body's own ability to heal at different levels. So whether or not it's prolotherapy, and prolotherapy, it's nobody's kid sister anymore. Prolotherapy is a giant. The evidence has come on, and I'm not going to step into Dean's lane, but it's a giant, it's good, it's safe, it's inexpensive. This is a comer, and it should be part of your armamentarium to take care of your patients because the evidence is compelling. And then we're going to look at the evidence more for PRP, bone marrow concentrate. Really, these are just, and if you talk to Arnold Kaplan, really what they're doing is it's just organizing tissue repair, these cellular components. So what comes next? This is what I'm disappointed in. Frankly, I was born in 65, we're going to the moon, I have no jetpack, I have no flying car, and I have no way to actually accelerate healing. So really all we can do is marshal the body's ability to heal and kind of set us on its course. But how long does it take to get better? 3 months is when we start seeing them get better, when the tissue actually starts really healing and they cross that threshold. And this is how I describe it to my patients, that you're having symptoms, you've been developing arthritis for decades, but it didn't bother you. And then you cross the threshold, all of a sudden became clinically apparent. My treatments, what I hope to do, is push you back under the threshold. I'm not going to give you a 20-year-old knee, but I want to push you back under the threshold. What I'd like to do is actually find something, some kind of Wolverine drug, some kind of something that actually accelerates the healing process. I'm not there yet. It'll come with my jetpack. This is the photo that keeps me honest. Traphening of the skull was independently developed on 6 continents over 6,000 before Christian era. 6,000 years before Christian era. Why was this done? Because they had very strong anecdotal evidence that showed that it worked. People came back for more treatments, and clearly this person, they lived, and they were doing better. So just because we have strong anecdotes doesn't mean anything to you. You really have to apply some rigor to your practice, some rigor in what you're actually doing for your patients. I like this organization we were talking last night, where what we cover is under 2 standard deviations of the mean of what's considered normal in medicine. But it's always good to hear the 3rd standard deviation, the outer edges that challenge you and make you think. That's good, but when you live, you better live pretty close to that mean. You better be based on solid research, and you better know why you're treating your patient, and you better be consenting them accurately as to what their options really are and what their success rates should be expected to be. A little bit about autologous therapies. So the FDA, if you're new to this, you're going to hear more about this, but really we can do same-day use of autologous stem cells that are subject to not more than minimal manipulation. This, using your own cells, are still subject to all your body's own regulatory systems. But that didn't stop the Australasian College of Sports Physicians from coming out with this statement paper. And really what they said is it should have the same 4-phase testing as a new pharmaceutical. Your own cells going into you should be subject to the same 4-phase testing. Why did they say that? And they said, hey, any use should be part of a registered trial and surgery. I'm telling you this because you need to be aware of this so you can refute it and say, hey, they're saying, well, even though there's never been a case or anything that showed tumorigenic potential from someone's own mesenchymal stem cells in their body, you just never know. And so that's what their point is. And if anybody's here that made these guidelines, I apologize, but my personal opinion is I think this has gone way too far, and I don't think there's evidence. The evidence does not support this position paper, but as a practicing physician who may do these therapies, you need to be aware that it's out there. The spine. Oh, this is a good time to be doing spine interventions with regenerative medicine. Why is that? It's kind of exciting. This guideline by Mulvaney et al. Just came out, 2019, hot off the press, and they looked at all the evidence. There's over 350 references and over 70 pages, and it just came out in Pain Physician. This is a high-impact journal. This is a very reputable journal. And if you want to understand this stuff in detail, I'm not going to cover it in detail, but this is where it lives. And frankly, they did a huge service and responsibly went through the evidence. So what they did is they said, hey, lumbar disc injections with PRP or BMAC, level 3. These were downgraded for perceived risk of bias, but it's still level 3. That's still strong. And if you want to look at the evidence that they have for surgery, it doesn't beat level 3. Lumbar facets, epidural injections, and sacroiliac joints with PRP, level 4. It's based more on case series level stuff or downgraded small size RCTs, but they still said, hey, it's level 4, it's good, it's safe. And if you look at what most pain interventions that we do are rated, they're level 4. So this is reasonable, and since we know that corticosteroid degrades thing in the back, and we know corticosteroid doesn't work, doesn't this kind of elevate this somewhat? We have something that works, that's safe, and we know corticosteroid doesn't work. We're working both ends of the scale. This is one of the well-done earlier RCTs that came out in discs, and really what they saw, the one thing I don't get is, for those of you that inject discs, they say 1 ml of contrast into a disc. You really can't get more than 1 or 2 mLs into a disc, so it seems like a very high amount. I'm not sure if they just put that down, but the PRP group did well. And honestly, for your younger patients that present with back pain or just central back pain, they are much more likely to have discogenic pain. As you get older, yes, you're going to bulge discs, but it's your younger patients really that are going to present with these injuries, and we really didn't have anything that worked for them. And now we have stuff that's working well. This is a small RCT that was done by Noriega and published, and they said, hey, in a lot of these studies, these RCTs weren't big enough necessarily to show causality, but they're on their way. And they are showing safety, and they are showing responsible follow-up. I just wanted to put in a little thing, hey, when it comes to prolotherapy, based on 14 RCTs and 18 high-quality cases, spine is a good place to use prolotherapy. I love this study by Dr. Smeagol. It's a very simple intervention, and it has very strong outcomes. I think it was originally done with 10 mLs of D5W, 2 weeks times 4, and talking to Dr. Smeagol now, she's up those volumes. Now it's more like 20 mLs of D5W. This is safe. The approach is safe. It's good. And if you don't have a coddle epidural steroid in your armamentarium to take care of your patients, you should consider getting training and applying that. Knee. Picture when I was in sports medicine fellowship, back when I could employ my active duty members as part of my treatment team. So I want to talk a little bit about emerging concepts, and you're going to hear more about this, but I think this is very exciting. The concept of just sticking something into a joint, that ship has sailed. That is so 1990s. Really, the concept is really thinking about the joint as multiple environments. You have the intra-articular environment where you're covering the cartilage surfaces, meniscus, the synovium. You have the extra-articular environment where you're covering the tendons and ligaments that support and stabilize the structure, in this case, the knee. You have the subchondral environment, and that's what nourishes, where all the nourishment to the cartilage comes from. And then you have, extrapolate on a fourth environment, and that's the nerves. And talking with Dr. Arnold Kaplan, the father of all stem cells, we have this conversation about nerves and trophic factors and how they're really responsible for the health of this whole organism, this whole joint. So 4 environments in a joint. And we need to start leaving the era of treating one thing and embracing the era of treating this as a system. These are my notes that I took when I heard Dr. Fizz talking about this concept when it came out of treating the knee with subchondral PRP and intra-articular PRP in severe cases, and they had excellent results. It was compelling data. So compelling I went backwards. But really, this study came out, it's well done, but it was a paradigm changer, or was it? So this is a study published by Ravigo et al. On dextrose prolotherapy, and what did they do? They treated 2 environments, intra-articular and extra-articular structures. In fact, prolotherapy has been treating multiple environments and joints since it was formed. So this is pretty exciting that a lot of these concepts that are now somehow getting more sexy validation, they've been around for a long time, and I think that you need to think about your approach to joints. Bone marrow and adipose-derived stem cells for knee osteoarthritis, systematic review of 6 RTTs. This is pretty well done and pretty strong, including 2 of those studies went back with second lip arthroscopy and evaluated the quality of the cartilage that was coming back. Superior outcomes. It was basically came out as level 3 evidence, and it was downgraded for perceived risk of bias, although these were larger scale RCTs and very well done, including with second lip arthroscopy. This is very compelling, but still, a real level 3, that's good. We'll take it. British Journal, it was published in British Journal of Sports Medicine. They're pretty conservative. They're not out there. So I would just like to acknowledge, I know Dr. Centeno is speaking later on in the conference, but I do want to acknowledge his work and efforts in the field. He published these large registry studies, and these are often cited for safety reasons that allowed a lot of the RCTs that came afterwards to happen. And I think it was pioneering efforts, and I thank him. I really counted on these studies that let me move forward in my practice. PRP and NEOA meta-analysis based on 10 RCTs. You're going to see a common. You're not going to see. It's not all cherry-picked evidence either. These are large-scale studies. This one just came out, and they say, hey. Now, if you look at the language, it's a little soft. It's a quote, may have more benefit. It's a little bit soft, but still, it's pretty compelling evidence for at least moving forward with this and seeing how things go. Labra et al. Published in 2017, 11 RCTs, and they basically looked at PRP versus HA and corticosteroid, PRP1, microfragmented adipose. This is another treatment modality that's out there. This is a case series, but showing safety and efficacy. PRP versus HA in the knee. I want to cover this to show you that I'm not cherry-picking evidence. This is a very well-done study that was just published in AJSM. 5-year follow-up, which is kind of crazy. Level 1 study, double-blind RCT. So we had PRP versus HA. They were using freeze-thawed leukocyte-rich PRP, which is not something that I think is a standard, what we call a standard PRP mix. Most people are not using freeze-thawed PRP, but okay. So both treatments were effective, but there was no difference in functional improvement between the two groups. I don't know about you, I have not personally, or do I know of people that have seen these kind of results with hyaluronic acid that were this sustained for this long. I just haven't seen it, but you have to respect the evidence. It was a well-done study, and we have to always reassess. We're not just riding down this track. We're constantly, if you're a responsible physician, reassessing the evidence. Hip, little less. PRP, basically PRP for the management of hip and knee osteoarthritis, 3 RCTs. They said, hey, PRP is safe and better than corticosteroid, which I would inject anyway. Corticosteroid is off my palate for that. This is a meta-analysis for hip. They looked at 4 RCTs, and this was just published in 2018. It improved outcomes at 2 months, but no difference at 6 and 12 months. So why is this? What's the disconnect that we're seeing here? The disconnect is probably that when you're treating hips, when you're treating particularly intra-articular hips, what do we know from cadaver studies? We know that the more diseased the hip is, the more likely that that hip joint space is going to have a communication with the iliopsoas bursa, virtually reaching 100% once you have a pretty diseased hip. So these people come in, we put something into their hip, and they stand up weight bearing into this ball and socket joint, which is almost like a syringe, squirting this out into a place where it doesn't have, into the iliopsoas bursa, where it doesn't have contact with the articular surfaces. I make all of my patients non-weight bearing at least 2 days, which is a challenge in older patients, and sometimes it means they rent a wheelchair. But I think that sometimes, we saw this discrepancy in studies with hyaluronic acid in hip, and we see this now in some biologics. And I think that none of these studies mentioned the period of non-weight bearing. That might explain this, but I'm not trying to justify, I'm just giving you the evidence. So this was a study that was compelling because the number's big. Over 1,100 cases where they were using adipose-derived mesenchymal stem cells. There were no adverse events at the harvest site, no adverse events at the injected site, and they had very solid improvement. It's a case series, but it's big. Shoulder. Shoulder is a little more challenging. So as we look at rotator cuff tendinopathy, 18 RCTs, both PRP and prolotherapy have significantly, they're superior over corticosteroids, NSAIDs, hyaluronic acid, and botulinum toxin, which I would like to mention a little bit about botulinum toxin. It's a toxin. It's poisonous. And I'll describe a patient briefly. I had a patient come into my office like this, holding her head up. And this is not the first time this has happened. Holding her head up, why? Because she got in a car accident. and she went and saw someone who did a botulinum toxin protocol to her. She had fatty infiltration up and down her trapezius, and she couldn't hold her head up anymore. She was holding it. We put PRP into the muscle, who responded very quickly. 10 days later, she was holding her head up and a very happy patient. These things are toxins. In the cosmetic literature, now they're talking about people that get Botox. Now they talk about how you have to do fillers after they've gotten Botox for years to restore the normal volume that's there because you killed it. So I don't think it's that great a modality. I consider it a destructive modality. Appropriate use of PRP. This was a study, PRP versus saline, rotator cuff tendinopathy, 1-year follow-up, included PRP was no better than saline. But what did they do? They were comparing subacromial injections. Now, if you're treating a tendinopathy and you inject into the subacromial space and it's within the tendon, how is that stuff, whatever you injected, magically going to get into the tendon? So when you look at the literature, you have to look at study design and make up your mind. Does this apply to me or my patients? That one did not. This is looking at basically HA versus PRP for partial thickness rotator cuff tears. Now, this was a little bit different because if you look, they were looking, it was double-blind RCT, good study. And they looked at PRP and hyaluronic acid versus PRP versus hyaluronic acid versus control. Bursal surface, supraspinatus tear. So if you put something in subacromial, it could get to a bursal tear. It could actually fill that little divot where it's at. Okay, this looks better. What'd they say? Hey, it worked well. But look at this. They did subacromial injections Q weekly times 4. I don't treat my patients that way. I don't know anyone that treats their patients that way, but okay, that's what they did. And they said, hey, PRP and hyaluronic acid or PRP had significant improvements over saline or the control. And it was, pretty compelling. Those are decreases in VAS, and it's something that makes you say, hey, in the surgical literature, hyaluronic acid and repairs is showing better tendon healing. It's showing better tendon healing here. So there have been studies with PRP and HA. It's still on the table. We should still consider it. VNAC and rotator cuff tears. This is from Dr. Centeno's publication that he put, but still it was a compelling. And what's interesting, in some of these, they take shoulder osteoarthritis and rotator cuff tears. Now, what they're not looking at is evidence of rotator cuff healing. They're looking at dysfunctional improvement of the shoulder, and that's a real goal. That's something that you can do. And I think with retracted tears, that is probably a bridge too far for regenerative medicine. But you can give them a nice, healthy shoulder. Microfragmented adipose, same patient population, showed improvements. Not necessarily rotator cuff healing, but improvements in their function. Prolotherapy for rotator cuff tendinopathy, double-blind RCT. This is nice. Prolotherapy for rotator cuff tendinopathy, another level 1 study. Q weekly comprehensive prolotherapy times 3. Okay, I don't necessarily bring somebody in every week, but they had good results. Maybe I should consider that. And when they looked at it, conservative therapy versus prolotherapy, the decreases in VAS were actually very compelling. So sometimes you look at stuff, you go, should I be adjusting my protocol? Should I be adjusting how I treat my patients based on that? This is a bit of a grab bag, but I wanted to be sure I could pull things under the tent. This is one, it was a study published in JAMA, and it kind of drove me nutty. This was basically they were comparing PRP to saline for Achilles tendinopathy. And both groups got Alfredson's protocol of negative eccentric exercise. In Alfredson's study, when they compared people that got negative eccentric exercise protocol, how many of them showed clinically significant improvement? 100%. So you're comparing a treatment modality where you had 100% of the people. So this is well underpowered to show any difference between saline and PRP. And basically, JAMA seems to like these kind of negative studies. Both groups got negative eccentric exercise, which is a very effective treatment on its own. So that's a study design thing. That you had to be, here was high impact journal. You need to be able to look at that and say, what does this mean? You need to go through this. You need to understand this. PRP and patellar tendinopathy, systematic review concluded, hey, you can use PRP as successful monotherapy. Pretty compelling. They looked at what was going on out there. There are other things that work. PRP is one of them, including extracorporeal shockwave therapy, which, hey, lateral epicondylitis, 8 RCTs. This is published in British Journal of Sports Medicine in Physician Sports Medicine in 2017, PRP 1. And we already know if you're comparing it to corticosteroid, the answer should be, why am I even talking about comparing it to corticosteroid? But we keep having these things. This is a nice RCT looking at severe plantar fasciitis. nice results. Don't forget to do them a solid and give them a tibial nerve block before you go sticking something in the bottom of the foot. Pure P and nerve healing. You don't see this come up, but this is actually very compelling because a lot of time the problem is the nerve. It's these entrapped nerves, and you need to address this in your patients. If you're not doing this, and the only tool you can go at these nerves with is ultrasound, and you're going to have to learn it, and you're going to have to learn it well because a lot of these nerves, they get entrapped, they cause pain, and there's nothing you're going to do that's going to take care of that entrapped nerve. PRP demonstrated positive effects on healing and nerve function as well as histological improvements in the nerve. I've been using basically, not thumping my own chest, but I did publish the first ever description of the technique of hyper-dissecting nerves. And then we went on even within the next year, we were using PRP, and we were using basically a leukocyte-rich PRP, which really lit up the nerve. And they were mad at me for about 3 weeks, and then they were happy with me. This stuff, you're healing this perineurium, and you're actually repairing the perineurium like you're repairing any other tissue. Current level 1 evidence, PRP improves PRP and scar management. Now, scar management, why are scars a big deal? Scars are a big deal because they affect fascia. And if you want to feel like a second-year medical student, go listen to this guy talk. Because every time I listen to him talk, I feel like an idiot. And I feel like there's a whole other end game, and that's really understanding fascia and nerves, fascial transports. This stuff is happening, and we're really playing checkers compared to the work that Dr. Fullerton is doing. But addressing scars is important. It's important for both cosmetic reasons, but functional reasons. If people have a scar, they entrap nerves, they limit function, and you can improve that. And you can improve their quality of life. You can improve their pain. Another one, autologous fat and scar treatments, and this is just basically showing safety and efficacy. It's a small case series, but it was actually well done, and they used true measurements of scar pliability and scar quality. And this is in plastic reconstruction surgery in 2017. It's level 4 evidence. They took it all the way to level 4. This is compelling if your patients have scars. Alpha-2 macroglobin. I don't want to step on Dr. Scuderi's talk at all, but the one place that I find that I don't make decisions based on animal studies, but this is a case where if someone ruptures their ACL, we know that whether or not they're reconstructed or not, they're going to go on to develop post-traumatic arthritis. We know this. The studies have been done. So what can we do to impact that ultimate development of post-traumatic arthritis? There was an animal study published by Wang et al. Where they looked at a rat-based ACL rupture model. The rats that they all had their ACLs ruptured, some got saline, some got A2M. None of the rats that got A2 went on to develop post-traumatic arthritis. All of the rats that got saline treatments went on to develop post-traumatic arthritis. I don't often base medical decisions for my patients on animal studies, but in this case, as I weigh what can I do for my patients, it's an autologous substance, it's their own, the likelihood of harm is small. Cost-benefit ratio. It's not inexpensive, it's probably more expensive, but they're going to go on to develop early post-traumatic arthritis. I was the team physician at Georgetown University. Almost every woman on the team, thanks to Title IX, have these, not Title IX caused their ACLs to rupture, but there's a tidal wave, a tsunami of young, healthy people that are going to be coming to your office with post-traumatic arthritis. This is something that may be avoidable, and this is something that may be compelling to you and your patients. I use it in the armed forces on every ACL rupture I saw after looking at that data and realizing I had nothing else to offer. And I didn't just do it once, I did it multiple times. I won't know the results of this, won't be known to me until, I don't know, for a while. Allograft products, this is a gray zone in FDA treatments. So I'm really not going to get into each one of these substances, but I can say some of them, like central tissue allografts, they've been around and used in surgery for over a decade. A lot of these products have demonstrated safety. Some of them do not. Some of them have made the news lately because they're not safe. When do I use? When am I compelled to use based on that same scale? So if my patient has a history of Waldenstrom's macroglobulinemia, if they have a history of bone cancers, blood cancers, these are people that now their autologous substances may not be safe for them. And an allograft may be the best choice if they failed other more conservative treatments like prolotherapy. So this is something, but having said that, that's a very conservative approach to this, and many people are having outstanding results. And really, this is probably represents the cutting edge, but I'm compelled in a review of the literature to say, hey, small, low-level case series So the decision, as I stand up here and I'm kind of giving you a battle plan, you have to know when I can tell you to advance and when I should tell you to hold. This is something where you have to make up your minds about. Many people are having successful treatments, safe treatments, impressive results. But I can't sit here and say, based on the evidence, that I'm compelled. The requisites, if you really want to get into this game, you need an expert level understanding of sternal anatomy. You need to understand the pathology. You need precise needle guided skills, and you need continuing education in an evolving field. And that's really where this organization, we hope we can fill that void or be part of your education. No one source should cover you. I have basically been interviewed on 60 Minutes. They're probably going to make me say something about casinos on the moon, because you never know what they are going to come out with. It seemed to be positive, but it was based on our multi-center RCT that we've done on cellular ganglion block for post-traumatic stress disorder. So I have no idea when it's going to get published, when that segment's going to come out, but it's nice that it's finally being paid attention to. Thank you very much for your attention.